Thank you very much, sir, for this opportunity. It's always a pleasure to present in front of I must say that living legend, Dr. Sharma. Two things happened. It's always a pleasure to meet every one of you in person. So that's one change happened this meeting. And the second thing is that we don't have to accommodate so much to listen to a talk. You can relax your accommodation. So management of congenital fibrosis syndrome, as you know, it's one of the CCDDs of many of them. Uh, what happens is it's a CCDD, you know that it's miswiring at the brain level. So whatever you do, there'll be suboptimal correction. This is what we must understand. And the second thing is it's pretty rare. But even if it is rare, there are, at least 10 or 12 cases will come in a year to a private practitioners. Probably in an institute, it'll be close to 40 or 50. This is what is the reality of this fibrosis syndrome. The culprit is here. KIF21A is the most important for the type 1, and the tubulin gene. These are the neurotropic genes which are defective here. Routinely, this is the classification which affects either oculomotor nerve or the nucleus of that, or trochlear nucleus and nerve, and its innervated muscles. So that's the whole pathology of this CFEOM. If you look at the classification, there are significant clinical phenotypes. It's not like one set of syndromes you see. There is the genetic classification is more informative. Otherwise, your classical textbook type 1, type 2, type 3 is not always true. So you have many varieties as close to 8 genetically defined syndromes. But the most common ones are these 3. This is important to really clinically, phenotyping in terms of type 1 is prominent, usually bilateral ptosis, which is symmetrical. Type 2 also, it's bilateral ptosis, may or may not be symmetrical. Type 3 is usually unilateral, not always. And the second thing you must remember is type 1 is usually hypotropic eye. It's not that always it's true. They can have a little bit component of exotropia as well. And the type 2 is usually exotropic. And some of the retinal dysfunction, pupillary abnormalities are seen in type 2. So meiotic pupil, if you see with CFEOM, mostly it is type 2. Mostly, it's not 100%, but mostly clinically you're right. And if you see any kind of neurological symptoms, findings, it's type 3. Type 1 is autosomal dominant, 2 is recessive, third can be autosomal dominant usually, but there could be germline mosaicism. It can mimic autosomal recessive. Why it is important? Because these are the 3 genes which are the culprits in these syndromes. And obviously, always have the pedigree chart ready. This is one of the typical autosomal dominant type 1 with the KIF21 mutation. And these are the clinical manifestations. You can see a large hypotropia. That's why I said it's not always just hypotropic. They can also have exotropia. Type 2 is usually very large exotropia with adduction limitation in both eyes, and normal abduction. They will have retinal dysfunction. Sometimes ERG is very important, and also looking at the finding of pupil is important. This is a typical type 2 CFEOM. Type 3, this is generally unilateral. They can have associated horizontal deviation. It can mimic like MED. It is possible with horizontal deviation. So you must differentiate. Sometimes it may be, genetic test may be required to really prove it or disprove it. And always observation is very important. Dr. Sharma showed that observation is very important. You might see some of the association. In this, what is common is the extraocular motility problem, and there is a novel mutation in chromosome 21q where they have absence of ulnar bone and also the finger abnormality. So they they will have something common in these kind of situations. This is common in Duane syndrome also. You saw it's not so common, but unless you search for this, you may miss these problems. I would like to just present 3 or 4 cases and then stop there, so that you will get an overview of the surgical management of these cases. Again, the goal of surgery is not really making them in ortho in all positions, making their life better, making their quality of life better. And you saw in the first title slide where the child was using the finger to open the eyes. It's a blinding disorder for many children. So that's what we are looking at. So look at this guy who has a very large abnormal head posture, hypertropia in primary position. He is not able to elevate. Krimsky's test is what we really use. Sometimes even that is difficult. Cover test, it's not possible in all the cases. You can see the abduction is good in the right eye, but there is significant adduction limitation in both eyes, and also elevation deficit. So obviously it's not that imaging is a must, but I just want you to show here. Normal study, you can see the muscles there, but in this patient you can see hypoplastic. It's not a myopathy, it is still a neuropathy because there is no nerve supply. The chromosomes of that is affected. That's why muscle underdeveloped. You can see what is normal in this patient is the superior oblique. Look at the size of superior oblique. That's why they will have a very, very large hypotropia in the primary position, because superior oblique. Sometimes you might have to do a superior oblique tenotomy also in these cases, in severe cases. So that's a comparison of normal and abnormal MRI, quasi-coronal cuts. The challenges are they do not follow any laws like a backbenchers. They have a significant pulley and insertion abnormalities. No rules for surgical dosage. Whatever tightness, you have to release it. But on table, if you can aim for overcorrection, that is the mantra for CFEOM. If they have a exotropia, if you can get a large esotropia at the end of the surgery, obviously it will be under GA. That is the good target, I must say, in most of the patients. Or even on the first post-op day, whoever has overcorrection, they have a long-term good outcome. You can also use stage procedure. Most of them are lost their binocularity. So sometimes you may have some of the pearls I would like to share here. While exploring SO, you will see that SO tendon insertion is abnormal. That's one of the things you can have. Tight superior oblique, and you can also have anterization of superior oblique, and also you can have KIF21. The type 1 may require a very, very large weakening. This is one of the paper by or one of our friend, Kumur Sener. All of you must read his paper. It's there on the strabismus surgery in CFEOMS. What he says is, what's most important is do a large recession, but have a counter traction. If you don't have it, over a period of time, they will come back. So you have to have that stay suture kind of things for some days. I personally don't use it, but he suggests in many of the cases it's important. And always look for fibrotic bands. This is for all the types of CCDDs. And what we did in this particular case is a very large lateral rectus recession and medial rectus resection. Left eye we did periosteal fixation because he was fixing with only one eye. We wanted to get it adducted so that he can correct his abnormal head posture, and also superior oblique nasal transposition. A lot of surgery has been done at the same time for this patient. So this is the 1 month post-op picture, and as I said, you can't make it perfect, but he is happy with this outcome, and still he is exotropic in that position. This is one more girl. You can see a large esotropia with hypertropia there. Amounts to, immediately it looks like a type 3, but if you see the right eye, there is a problem there as well. So we haven't done the genetic test in this case because she had not any inclination for that. So, but we don't know. But you can see this hypoplastic muscles on both sides, especially the superior rectus you see on the left side, and also oculomotor nerve abnormality. And we did the inferior rectus and the medial rectus. It was super tight. We relaxed that, and then you can see she's not bad again. She's happy with the outcome, but still she has a little bit of abnormal head posture, and she's doing well. This is again one more large esotropia. With that we did the surgery, and you can see when you correct the esotropia, even the ptosis became better. He did not have additional ptosis surgery here. And that's the last case I'm going to show. Very large exotropia. We had to do a very supramaximal resect for this patient, and you can see still it's not perfect, but we could get this is what I just wanted to show on the table or on the first post-op day. Look at the middle picture. It looks she looks much better, but see what happens after 2 months. It still diverges. So these muscles, in spite of having overcorrections, sometimes over a period of time they can have. This is the pre-op head posture. This is the post-op head posture. So to conclude, I would say careful force reduction test is very important, and then you can do a large recession. Best results are expected in patients with CFEOM type 1 who can expect a marked improvement in head position and acceptable ocular alignment in primary gaze after recession of inferior rectus and ptosis. Due to the rarity of this disease, surgical treatment can pose a great challenge. It's not that two cases are similar. Each case is different. Investigating for associated abnormalities are important. If possible, one must do the genetic counseling, because this is important, because many times they can come with the thing. It's only to improve the quality of life, not a perfect alignment in these cases. Thank you very much. I just would like to invite you all for the 4th grand rounds in pediatric ophthalmology and strabismus in Kolkata in August, and also WSPS meeting in Milan. If you all would like to go abroad, you're all welcome, and the deadline for abstract is June 7th. Thank you very much.